Hello, everyone. I'm very pleased to join you in this important virtual meeting. And first of all, I'd like to thank the organizers of this important Congress to talk, to give me this opportunity to talk with you about the future of sickle cell disease, the role of crizanlizumab for optimizing the outcome. These are my disclosures. I am a Novartis consultant and a member of the advisory board on sickle cell disease, and I will not discuss of labeled drug use in this presentation. As you can see in this figure, life expectancy of people living with sickle cell disease has increased over the last 4 decades, particularly for children under 6. As you can see in this slide, despite the advances in the management of sickle cell disease, people with the disease lives more than 30 years less than the general population. And to make this scene worse, the quality of life of people with sickle cell disease is much worse than the general population. So the emerging disease-modifying approaches to sickle cell disease, including new drugs that target different underlying mechanisms in the sickle cell disease. And today we are going to talk in detail about crizanlizumab. Crizanlizumab is a P-selectin inhibitor, a humanized monoclonal antibody binds to P-selectin present on the endothelial cells and platelets and blocks its interaction with P-selectin receptors present in sickle cells and leukocytes. Once given, crizanlizumab binds to and inhibits P-selectin, thereby blocking its interaction with the receptor, preventing vaso-occlusion. The SUSTAIN trial was published 3 years ago, and it was a phase 2 multi-center randomized placebo-controlled double-blinded study to assess safety and efficacy of crizanlizumab in sickle cell disease patients with VOCs. From August 2013 to January 2015, a total of 198 patients at 60 sites, most of them from the United States, and 40 Brazilian patients. The inclusion criteria were patients aged 16 to 65 years, all sickle cell disease genotypes, between 2 and 10 VOCs in the past 12 months, with without hydroxyurea. And the main exclusion criteria was being on a chronic transfusion program, planning on exchange transfusion during the study. Okay. This is the study design. So almost 200 patients randomized into 3 arms. The crizanlizumab 5 milligrams per kg per day was named high dose. Crizanlizumab 5 milligrams per kg per day as a low dose, and a placebo. Patient received 2 doses of crizanlizumab or placebo 2 weeks apart, named loading dose, and then received a dose every 4 weeks through the 50 for a total of 14 doses. And each dose of crizanlizumab was administered IV over a period of 30 minutes. The primary efficacy endpoint was the annual rate of VOCs in the crizanlizumab groups versus placebo, and the secondary endpoints, the number of hospitalization days per year, the time for the first VOC, and time to the second VOC. Here we have the characteristics of the patients in the three groups, and as you can see, they are very similar. And about 70% were genotype S, 62% of the patients with 2 to 4 VOCs in the 12 months previous the study, and 37% with 5 to 10 VOCs in the previous year or treatment. And as you can see in this slide, and 62% were on hydroxyurea. Compared to placebo, high-dose crizanlizumab resulted in a 45% reduction in annual rate of VOCs, a reduction statistically significant. It's another important result is that 36% of patients with high-dose crizanlizumab were VOC event-free at 52 weeks, compared to 17% with placebo. And results were seen regardless concomitant use of hydroxyurea, the genotype, or the number of VOCs in the previous year. As you can see in this figure, the time for the first VOCs was significantly increased. 4 months for those receiving high-dose crizanlizumab versus 1.4 months with placebo, and a difference statistically significant. According to the second VOC, the similar results were seen with regard to the median time to second VOC. 10 months with high-dose crizanlizumab versus 5 months with placebo. And, a difference also statistically significant. And the median rate of days hospitalized was 4 days in the high-dose crizanlizumab arm and 7 days for the dose on placebo arm, a reduction of 42%, although the difference was significant. And the annual rates of VOCs were also analyzed according to subgroups defined as histories of VOC frequency, concomitant hydroxyurea use, and sickle cell genotype. Among patients not receiving hydroxyurea therapy, the median VOCs rate per year was 50% lower with high-dose crizanlizumab, and this difference was significant. Among patients with concomitant hydroxyurea therapy, the median VOCs rate per year was 32% lower with high-dose crizanlizumab, and the difference was not significant. Among patients who had 2 to 4 crises in the previous 12 months, the median VOCs rate per year was 43 lower with high-dose crizanlizumab, although this difference was not significant. Among patients who had 5 to 10 crises in the 12 past months, the median VOCs rate per year was 63% lower with the high-dose crizanlizumab, and the difference was significant. And among patients with SS type, the median VOCs rate per year was 35% lower with high-dose crizanlizumab, although this difference was not significant. And among patients with genotype other than SS, the median VOCs rate per year was 50% lower with high-dose crizanlizumab. Again, the difference was not significant. One thing very important is the impact of crizanlizumab on opioid need. As you can see in this figure, people with 5 milligrams per kg per day of crizanlizumab had a related reduction in annual days of opioids about 57%, and a reduction of parenteral opioids about 50%. It's a very impressive data that we have now with these years using crizanlizumab. So the SUSTAIN study means that clinically meaningful lower rates of VOCs were observed with crizanlizumab 5 milligram pig than with placebo, regardless of concomitant hydroxyurea use, number of pain crises in the previous 12 months, or sickle cell disease genotype. And high-dose crizanlizumab effectively blocked the P-selectin throughout the treatment phase, and crizanlizumab did not decrease hemolysis and did not increase hemoglobin. As you can see in this slide, we can see the serious adverse event was very low and was similar among the three arms: crizanlizumab 5 milligrams, 2.5 milligrams, or placebo. So, but there are many new questions, open questions after the SUSTAIN trial. One of these is 5 milligrams per kg the optimal dose? And now there are ongoing trials like the STAND trial. It's a phase 3 trial, randomized, to assess the efficacy and the safety of 2 doses of crizanlizumab, 5 milligrams per kg or 7.5 milligrams per kg versus placebo. And another open question is crizanlizumab benefits beyond the VOC, like acute chest syndrome, stroke, nephropathy, retinopathy. And now it's another trial ongoing, the STEADFAST. Is a phase 2 multi-center randomized trial analyzing the crizanlizumab on renal function in patients with chronic kidney disease due to sickle cell nephropathy. And another question is crizanlizumab benefit in patients with mild or more severe sickle cell disease complications, and about children, crizanlizumab safety and benefits in children. So now there is a trial, a SOLAS Kids trial. It's a phase 2 open label trial to assess appropriate dose and evaluate the safety of crizanlizumab in pediatric patients with sickle cell disease. So, in summary, new mechanism and first demonstration that P-selectin inhibitor reduce the frequency of VOCs complications in patients with sickle cell disease. No major safety concerns. Indicate to reduce the frequency of VOCs in adults and pediatric patients aged over 16 years with sickle cell disease, and is already approved by FDA in 2019 by Anvisa in Brazil in last year, and from the Europe, many countries in the Europe only last year, based on this single study, the SUSTAIN study. Thank you very much for your attention.